Bismillah ar-Rahman ar-Rahim. Good evening, ladies and gentlemen and colleagues. Good afternoon, Switzerland, and good morning, Canada. It is one of our pleasure to welcome you all this evening for this webinar. It is titled Coronary Artery Bypass Surgery. This is an operation that stood the time as a cornerstone intervention, offering significant survival and to some extent benefit in relation to symptoms of this specific population. My name is Dr. Habib Tarif. I am head of cardiac surgery in Bahrain, and I'm a member of the executive committee for the Gulf Society of Cardiac Surgery. Chairing this session with me, Dr. Adel Tash. He is a senior cardiac surgeon, a leader and strategist. He is the CEO at King Abdullah Medical City in Mecca, Saudi Arabia, and president of the Saudi Society for Cardiac Surgery. Also joining us, Dr. Mohannad Al-Dori. He is a resident at King Faisal Specialist Hospital and Research Group, and he is the head of the resident group at the Gulf Society for Cardiac Surgery. So the Gulf Society, just a small thing about the Gulf Society for Cardiac Surgery, is a member of Gulf Heart Association. This society is established back in 2023, and it consists of members from the regional countries, that is six Gulf GCC countries, in addition to Iraq and Yemen, so that we are 8 countries in this region. The mission of the Gulf Society for Cardiac Surgery is to promote excellence in cardiac surgery, facilitate professional networking and collaboration among cardiac surgeons in the region, and advance education and research in this critical field. We are committed to continuous professional development of our members, fostering a collaborative environment that enhances the quality of cardiac care available to patients across our members. One of the objectives is professional development for cardiac surgeons through educational events, enhancing collaboration and knowledge exchange. With this comes this webinar. So without due force, I'm giving the floor for Dr. Adel. He is chairing the session, and he will introduce the first speaker. Dr. Adel, the floor is yours.
Thank you very much, Dr. Habib, and I would like to welcome first of all, our dear panelists and our dear speakers, and our fellow and colleagues from the residents and other participants in this important webinar. That is really just a continuation of what the Gulf Society for Cardiac Surgery is adding to the cardiac surgery community in our region. It gives me great pleasure to introduce Professor Mustafa Shiagaglu from Switzerland. Professor Mustafa is the vice chairman and the head of adult heart surgery at the University Hospital in Geneva and Faculty of Medicine. He has many academic roles in Istanbul, and he leads the heart and endocarditis teams and specializes in adult cardiac surgery. He is an academic surgeon. He has more than 200 publications and served as the ESSR president from 2013 to 2015. He is on the European Board of Cardiothoracic Surgery panels, reviews for journals, and has received awards, including the Gore-Tex Best Young Investigator Award. He leads resident training and simulator programs at the University of Geneva and the Swiss Academy of Heart Surgery. Professor Mustafa, the floor is yours to talk about preparation and planning for coronary artery bypass grafting.
Thanks a lot. Do you hear me?
Yes, we can hear you clearly.
Now, as usual, there is a problem. Just last seconds, I lost you. Let me to reconnect. All right. Here we are. And just to be sure, do you see my screen?
Yes, we do. We see the globe. the earth with lines on it.
Great. Here we are. So, Assalamu alaikum. Hello, everyone. As presented, my name is Mustafa Sikiriksioglu. Originally, I'm from Turkey and based in Switzerland more than 20 years. And recently, for more than 10 years, I am interested mainly for adult heart surgery. I am responsible in our group for adult heart surgery. Again, just to be sure, you have the screen.
Yes, Professor Mustafa. We have the screen in front of us.
My task is today to share with you, with my young colleagues, the important part of coronary artery bypass surgery, the planning, preparative investigations, and the individual strategies. And I'm a big lover of the mottos, proverbs, and the quotes. And I would like to start one of them. The best way to predict the future is to create it. Mainly used first time by Peter Drucker, and then became a motto for myself and for my colleagues who is working in the field. And I believe Gulf Society Cardiac Surgery and resident group is making the best investment to create the best future in the region and to help the people suffering with heart pathologies by organizing this kind of meetings and investing the future by helping the training of the young colleagues. And you mentioned already on my CV, but I'm a big believer of a heart team, including young colleagues, and I am also a big believer to invest the future by training the young generation. So my task was today to talk about how we prepare our patients for the best results before the operation, before performing the coronary bypass surgery. But before thinking what kind of investigations, strategies we think for all patients, I ask every day before operating a patient, including coronary bypass surgery patients or whatever cardiac surgery patients, 5 questions, mainly focused on CABG patients. Is coronary bypass surgery the best treatment for our patient based on his current conditions, which I'm underlining because the conditions may change? May I achieve complete and durable revascularization on this patient, on his heart, her heart? Which conduits will give the best long-term results? What are the patient-specific risks which I need to be aware and be prepared, because failing to prepare, preparing is to fail. And where can this operation fail? So preparative discussions with your patient and your colleagues, preparative investigations must provide the answers to these questions before going to the operating room. For each doctor, for each surgeon, the first question working in the field, we need to ask ourselves, okay, we want to help to our patient with different kind of treatments, surgeries, but first aim by helping, we should not harm our patient. This is the quote belonging to Hippocrates. And just based on this principle, I should say the 2 guys which you see on this picture most probably today would not fit on the same point if they were sharing the same table or discussion on the same patient. On the left-hand side, you see my picture just as a young surgeon after having my license as heart surgeon, much more mechanistic person and very eager to operate. The other one is recently taken, and after having more than 20 years experience in heart surgery. Just mainly the right-hand side learned, it doesn't mean the best techniques proposed by the guidelines by other surgeons could be applied to your patient and can be used always on your hands or in your center. And the funny part also, my daughter was not able to really recognize the person on the left-hand side She is 8 years old, and she was asking to me, who is this person? Actually, it's me. And with white hairs, I added some experience. Before going also for my young colleagues, for young cardiac surgeons, I should underline the importance of not looking percutaneous coronary interventions as the enemy or enemy procedures. PCI and CABG, two different techniques, and they are not competing to help to our patients. They are mainly complementary procedures. One is difficult for one patient in one situation. We need to think the other one. So therefore, we can really help to our patients. The talk is not only about surgery, about more humanistic and medical point of view, because what I learned also during the schools or training camps in EACTS, the young colleagues, they like to hear our heroic presentations, heroic interventions, but also they want to see the real life scenarios, real life patient presentations, and real life lessons. Let's now move to a patient presentation. Mr. AAF, it's a 55-year-old patient. Very interestingly, he is from Kingdom of Saudi Arabia. Recently, it's one of the patients which I was working on and I was involved. He is known with type 2 diabetes and treated with anti-diabetic medications, hypercholesterolemia, hypertension, and just he is coming for 5 days business travel to Geneva. After arrival, the next day, he has a chest pain with a light minor effort by walking and coming to our emergency department. The ECG shows well-known left block signs, but without real ischemic signs on the ECG. And the patient the next day had the coronary angiography, which shows us without having the left main coronary artery disease, very tight lesion at the beginning of the LAD, and then on the main very strong marginal artery, very tight second lesion. When you are looking the LAD branches, also there are two small diagonal arteries. The first one is negligible, but the second one is important. And the other injections also confirms the triple vessel disease, but without having severe lesions on the right coronary artery system. So we are involved in discussion of the patient's file in this moment. The troponin T levels were increasing, and it was about 304, and the patient had the end-stage diagnosis. But when we saw the patient, no chest pain, under optimal medical treatment, and then we decide, let's follow the patient evolution. If he will have chest pain, ECG changes, we can intervene quickly or discuss the options quickly, but otherwise, let's discuss tomorrow because it was almost the end of the day. And the next day morning, the plateau obtained for troponin T levels, patient had got during the night no chest pain, no ECG changes, and the stabilization of the troponin T. So during the heart team discussion, we were talking about a patient, three-vessel disease, young patient, male, diabetes mellitus, known low ejection fraction, but not very low than 35% as described on the guidelines, no ongoing ischemia. The patient has a high risk to transfer him to country of origin, and then we said CABG is superior for long term. If it's a local patient, most probably 99-100%, we should really push the patient toward CABG, and PCI inferior for long-term results, but gives the advantage of faster, safe transfer to the country of origin the patient. Let's discuss and present our opinions. And eventually the patient wanted, I think I would do the same if I would have a congress in Riyadh, and then I would have an NSTEMI, mainly to improve my symptoms, and then let me to return to my country. And eventually, the cardiologist, the next day, they implanted in treating this tight LAD lesion without losing the diagonal branches, and also treating this marginal tight stenosis. So why I'm entering with this patient, we are talking about the coronary bypass surgery, but it doesn't mean this is the only treatment while talking on coronary artery disease patients. When we are talking about preoperative investigations, preoperative strategies, we have two main scenarios: elective presentation and stable coronary artery disease patients, or emergency patients with ongoing myocardial ischemia having acute coronary syndromes. In Geneva, for elective patients, we have certain basic standard preoperative investigations. One of them is transthoracic echocardiography to have the information about the left ventricular ejection fraction, right ventricular function, and then any additional valvular pathology, and to also analyze the proximal part of the aorta. Carotid-vertebral Doppler ultrasonography is one of the exams which still we are keeping on, despite there are certain departments not applying for all comers. But in our unit, it's one of the examinations which we keep on as a standard investigation. For the patients older than 65 years old, whatever surgery, open heart surgery, we ask non-injected CT scan in order to assess the aorta clamping levels. This age limit is advised on the guidelines as 70, but in Geneva, we are a little bit more careful and decrease the age limit. One of the tests in the past we were making as a standard for all comers, pulmonary function tests, spirometry, but now we excluded this test by seeing it's not changing too much the outcomes of the patients, except if the patient is well-known COPD disease, bronchodilator treatments, and then heavy smoker patients, barrel chests informations, and then clubbing, etc. In these subgroups, we ask. And then preoperative graft assessment is one of the main exams. We ask for each patient from one of the specific units called angiology department. Those are the internal medicine doctors specialized to assess the peripheral artery disease and the conduits. It's one of the musts for elective patients. Always our anesthesiologists, they see the patients before the hospitalization. And for particular patients, fragile patients, which requires longer intensive care unit hospitalizations, we ask also assessment by ICU specialists. In case needed, just to see which part of the heart really requires the revascularization for particular patients, or the myocardium is viable or not, we add the PET CTs, MRIs, or stress transthoracic echocardiograms. Additional coronarography sometimes for non-critical looking lesions and debatable lesions, sometimes rare, but when I'm asking to my cardiologist, or they are doing spontaneously, optimal coherence tomographies in order to evaluate the proximal part of the LAD or left main lesions, and then adding some flow studies like FFR and EFR, very well known based on FAME studies. And the current medical treatment of the patient should be always asked, investigated, concerning excluding the double antiplatelet treatments, vitamin K antagonists, or direct oral anticoagulant medications. For our patients, it's one of the standard radial artery grafts we use almost in a routine base, prepared by harmonic scalpel. And its very well-known test is modified Allen test, but we are using mainly Barbo test, which simply you can put an oximetry probe on the index finger, and then by doing exactly the same maneuvers like Allen test, you can read the digits and then you can confirm quantitatively if there is a problem with the pulmonary circulation or not. And also for our patients, we are making the preoperative saphenous vein screening, and then in the operating room, also our team mainly making the preoperative pre-incisional mapping in order to prevent some wound troubles because of non-well defined localization of the saphenous vein. For the medications, for our team, ticagrelor, at least we need to stop before the elective operation 3 days, clopidogrel 5 days, prasugrel it's 7 days. Recently, we started for critical patients who may need quick surgery. Instead of giving these antiplatelet medications, cangrelor, which should be stopped 1 hour before the surgery. The vitamin K antagonists, we stop generally 5 days before the surgery and bridging with heparin. Despite some companies, they say direct oral anticoagulants, you can stop 1 day and the next day you can operate patients. This is not true for major surgeries like heart surgery. For minor surgeries could be, but mainly these patients should stop their DOACs at least 3 days before. And if they are well known with chronic renal failure, it should be 5 days before the surgery is stopped. For the patients under ticagrelor treatment, if you don't have a chance to stop longer, then cytosorb, it's confirmed and also used in our team, like an absorption or eliminating method for the patient having DAPT with ticagrelor. And also recent case report, we confirmed apixaban DOAC. You can do the same effect by using the cytosorb. So mainly in our team for elective patients, we are using full arterial CABG techniques younger than 75. Multiple arterial CABG, we don't have any age limit. As possible as we like to use arterial grafts, but on the other hand, we don't exaggerate. Main aim, let the patient first pass the acute period and then invest for the future. Almost 99.9% we use Lima on LAD and Lima for almost all the patients, emergency or elective. And our default technique, we are not an off-pump department because of the low volume patients, on-pump CABG on arrested heart. But hostile aorta or certain specific patients, we use beating heart techniques. If we are not able to completely revascularize these patients, we combine with hybrid procedures. For emergency, I should say, there is no room for CABG. So the guidelines and our belief, my belief, if we are in front of a patient with ongoing coronary ischemia, myocardial suffer, the patient should have as fast as the myocardial revascularization, and we cannot catch the speed of the cardiologist, the PCI, in these situations. So we give the room to the cardiologist to revascularize the patient quickly. And also the statistics shows worldwide the coronary bypass surgery for this kind of STEMI patients with ongoing ischemia, it's going down. The reason, because there is already an ischemia, and with your spatially cross-clamped coronary bypass surgery, this impact of ischemia will be doubled or tripled, and the reperfusion injury, it will be much, much, much more. And our criteria, especially if the patient is having more than 5,000 troponin T or CK and CKMB values higher than these, generally, we try to keep the patient away from surgery because these patients have high risk of mechanical circulatory support. We are using the magic solution called, used a lot and presented by our team also, glucose, insulin, potassium on this kind of emergency patients, really if we need to make a surgery because they are having low ejection fractions. And on these patients, this kind of solutions confirmed by different studies and our study helping to recover faster after the surgery. The same rules for the medications. The worst, if the patient has already some strong DAPT, then this is also one of the reasons to not take to the operating room the patients because of the high risk of bleeding postoperatively. Arterial grafts are good investments for long term, but these patients need acute, big myocardial flow. And in our study, what we show, the arterial grafts increase within 10 months their flow 2-3 times more than saphenous grafts, but in the early time, their flow capacity is much less. So the guidelines are giving us the right in case if we will operate the coronary patients in emergency situation, use only one arterial and the rest venous, or all conduits as venous conduits. To conclude my presentation, I want to give also another example. 82 years old patient, much older than the first one, has history of smoking, diabetes mellitus, low ejection fraction, and then known with heart failure hospitalizations. And the patient has a huge file, doesn't look really a good surgical candidate. And when you look, the left main more or less is okay, but the proximal LAD lesion is quite calcified and complex and difficult lesion for percutaneous revascularization. The patient is discussed in the heart team, and by looking the image, right system is okay, but left system accepted as a high risk lesion by the cardiologist. And mainly they gave us the first place if we can operate and help this patient by a Lima LAD coronary bypass. By looking and investigating the patient before the operation, I agreed the lungs are not really in a good shape. The patient had some perhaps memory disorders, but after seeing the patient, he was quite fit, much better than shown on his file. And then he had really impaired left ventricular systolic function with viable myocardium, which is mainly on proximal LAD territory. The spirometry on this particular patient I wanted to ask was confirming me the patient may pass this operation, but perhaps by excluding the cardiopulmonary bypass with his age and his conditions. What I need to do, I took the decision. So bleeding heart, Lima LAD bypass, spinal anesthesia, and we call it in our institution ultra fast track. After COVID, we adopted this technique by extubating the patients on the table, not within 2-4 hours postoperatively, but very fast. And the coronary flow on the bypass graft was good. And the patient, after the surgery, of course, took time a little bit with his age, but went to the rehabilitation unit and recovered well. So I'm advising to you when you see a coronary patient, analyze the patient file well, talk with your patient, and examine him, her, yourself. And I ask to you, walk with him, her, yourself. To see a patient in the bed or just by walking, you get a lot of information, personal advice from your older brother. Make a balance in your mind which technique will help to your patient according to his, her expectations. Not, it doesn't mean you are a surgeon, you need to operate all the patients and you are obliged. Inform the patient about the risks and benefits, advantages and disadvantages of both treatment methods, PCI and CABG. On the other hand, by hoping the patient is not oriented before your visit for other treatment, in that case, it's a little bit difficult to change the brainwash of the patient. Allow the patient time to think and respect the patient's decision. Remember that our comments are the proposals, but the final decision respectfully made by the patient. Another quote I love, by failing to prepare, you are preparing to fail. And these investigations help to you to prepare your operation. A good CABG operation begins long before the first incision. The operation is the execution of a plan. Every patient requires an individual strategy. Investigations must answer specific surgical questions. Good surgeons operate well. Great surgeons plan well. Thank you. And with this occasion, I would like again thank to the organizers. Another quote, I believe there are no foreigners, there are new friends. Before, I didn't know Dr. Adel Tash, Habib Al-Tarif, and Mohamed Davari, which were, for me, 1 year before, 2 months before, foreigners, but they are now my new friends. And I would like again thank to the society and the organizing group of the residents by inviting me, giving me this honor. Thank you. Shukran.
Thank you very much, Professor Mustafa. Thank you for the nice words and hope that we have a long association. We come for our next speaker, Professor Teresa Kaiser. She is Professor Emerita of Cardiac Sciences and Cardiovascular and Thoracic Surgery at University of Calgary, Lippin Cardiovascular Institute. She founded the Cardiovascular and Thoracic Surgery program at Foothill Medical Center in 1988, specializing in total arterial and bilateral internal mammary artery grafting. Her research, including her PhD on BIMA grafting, and inform international guidelines, and she has been teaching in the European Association Cardiothoracic Surgery Academy in the skill program. She operates and teaches internationally, holding an honorary contract at Royal Brompton and Harefield at National Health Institute in UK. Dr. Kaiser chaired the advisory board of the KIBO's International Health Foundation, supporting sustainable cardiac care in Kenya. We are pleased to have her with us this evening, and she's going to talk about conduit selection, technical and evidence-based approach for what conduit you use. Professor Teresa, the floor is yours.
Picture. Okay, good. Thank you, Dr. Habib, for that very kind introduction. I'm going to share my screen. Let's see now. Okay. Good evening, dear colleagues. I am honored and delighted to be with you here this evening. Assalamu alaikum. And if they're watching, a special hello to three lovely young women from the kingdom, Noura, Ibtisam, and Suha, whom I had the pleasure of meeting just 3 weeks ago at the EX Academy's fundamental course in coronary surgery in Windsor. They will be heart surgeons one day, inshallah. This is my first time speaking to surgeons in the Middle East. Thank you from my heart to yours. My arteriografting experience, the first 15 years, 30% BIMA, the last 20 years, 78% BIMA, with this is 98% arteriografting. These are my disclosures. I'm going to just move this a little bit. There we go. We're going to talk about bilateral tumoral mammary, radial artery, saphenous vein, gastrocleptic artery, inferior epigastric, and stents. First, let's look at comparison of IMA and vein grafts. Why are vein grafts not so good? They're never meant to be arteries. Some last 30 years, but most don't. Common sense. Blood pressure in leg veins is 60/25 millimeters mercury. Blood pressure in arteries is 120/80. Why are IMA grafts so good? Because God made them that way. They are a drug-eluting conduit. They secrete prostacyclin and nitric oxide. Alfieri in 2007 wrote an editorial and called them drug-eluting conduits. They're composed mainly of elastic fibers. They have nutrition from the lumen, rich lymphatic drainage. They auto-regulate in response to demand. And location, location, location. God is probably wondering why his humans go to the farthest corner of the body, the ankle, for these conduits, when he put the best right beside the heart. Vein graft patency has not changed in 50 years. Fitzgibbon's seminal paper in 1996 showed at 3 weeks, 12% of vein grafts were occluded. A later paper by Kimon Kim showed 11.8% occluded. Then at 1 year, Fitzgibbon found that 19% of vein grafts were occluded, and the PREVENT-4 trial by McGee, 25.5%. Fitzgibbon, in late 1996, after 15 years, found 50% occluded, and Tatoulis, with another sizable amount of vein grafts, 50.7% occluded. This is a PubMed search for papers on saphenous vein patency. In 57 years, there have been published 2,176 papers on saphenous vein patency. Then this is IMA patency. Again, 1,835 papers on IMA patency. This is a total of 4,011 papers on the same topic of conduit patency, 70 papers per year. Which group is wasting their time? Instead of going through 4,011 papers, I decided to pick 2 papers from reputable centers recent. This is April 24 from the Australian group. Alistair Royce was the senior author, and it was a total of 983 patients with over 3,000 grafts, median follow-up of 8.6 years. The patency of the radial artery was 86.9, internal memory 93.9, and saphenous veins 72.8. And then perfect patency, they also measured perfect patency, 86.4, very similar, internal memory 93.5, and the saphenous vein had only 46.2%. Where is this paper from? Melbourne, Australia. Dr. Brian Buxton, a world leader in cardiac surgery practice from 1978 to 2009, he started this arteriografting program and has lasted 50 years. They know how to do this. The second paper I chose was from Domingo Souza, who championed the no-touch technique, and this was published again in 2024. 20 consecutive patients, single-centered, their center, over 15 years. Mean follow-up, 8.4 years, very similar. Patient group was 825 conventional versus 618 no-touch, and 77 patients had no veins. They were total arterial. Patency per patient, conventional harvest was 46.7%, no-touch veins 70%. It's better, but patency per graft, 62.8%, 75.9% no touch. So certainly the no touch technique has improved the harvest. But we just saw Roy's et al. IMA had 93.9%, radial artery 86.9% at 8.6 years. Why do surgeons not use BIMA? BIMA takes longer, but we are no longer barber surgeons. We don't need to be so quick. We have general anesthesia. Reluctant to believe in the superiority of BIMA over CIMA? There are technical challenges of 2 IMAs. There is perceived conduit coronary flow mismatch and the risk of sternal wound infection. How does the REMA reach the back of the heart? It is brought through a hole in the pericardium near the superior vena cava and then through the transverse sinus as the crow flies. In a series of 1,057 patients over 10 years, in situ was possible 91% of the time. And I use the same hole for the REMA grafts to the right coronary artery or posterolateral branch of the right. How does the REMA reach the PDA of the right coronary artery? Brought extrapericardially. This is outside the pericardium, through a hole in the pericardium near the inferior vena cava to reach the PDA. In the same series of 1,057 patients over 10 years, in situ was possible in 89%. The turn point of the IMA, and this is important, is at the pericardial edge, not at the heel of the IMA. Here is a skeletonized IMA with a harmonic scalpel. There isn't enough time to talk about this topic, but I just want you to see the dilated mammary, not bruised, and the little branches are sticking out like twigs, not clipped, not causing any turbulence of flow inside that artery. At EX Academy, have a wet lab, and this is one of the favorite stations of the students. This is a prone pig. You remove the backbone so you can harvest the mammary and 2 veins on both sides by the students closer to the heart. This is a student practicing with or learning how to use the harmonic scalpel. Toward zero. Okay, this is a paper that we published. Over years, I had been right from the beginning of my job. I've been adding things to make the surgical procedure better without infection. I have never used bone wax since I started my practice. Skeletonization of the IMA, the vancomycin paste, avoidance of BIMA in one subgroup of diabetics, and change to chlorhexidine alcohol were the main ways that the infection myostatistician thought stop the infection because of the time frame. When I started my practice, I started by just recording. If I changed my practice, I recorded the date I started, and I didn't go back and forth with the technique. I kept doing every single patient with that technique, and it really paid off with this paper. So let's look at these diabetics. There were 1,001 CABG procedures, 16 total, which is a rate of 1.5% infection rate. That's okay. But when you know that all 16 were in the first 532 bypasses, it was 3% versus 0. P-value was very significant. 6 of the 16 were in women, BMI greater than 30, and with diabetes. That was 38%. Here's another way to show this. Here, the only outlier is the women BMI over 30 diabetics. And all of these had an infection rate of 2%, whereas the women had 21.4%, 10 times. So in conclusions, this study of 1001 bypass procedure with 98% arterial grafts, 73% BEMA, and 35% diagnosis, the risk of deep sternal wound infections can be reduced to close to zero with multiple infection prevention measures. I would never say zero because God will come down and go, bang, we've got 3 in a row. So infection, this is very important, is usually caused by transgression of several barriers to infection. Prevention of infection may be caused by adding multiple layers of prevention. It is prudent to avoid BEMA in one subgroup of diabetics, women with BMI greater than 30, which was only 13% of diabetics in this study. All other diabetic subgroups do not have an increased risk of deep sternal wound infection, and the majority of diabetics may benefit from BEMA without this increased risk. Since the last infection of this series, April 2008, 2 deep infections occurred in the subsequent 1,490 bypasses, which is a rate of 0.13%. Here are some slides to show what you can do with the memories. This is a sequential lima to a diagonal and LAD. You can see it joining up to both areas. Then this is a composite lima to LAD with itself. I took the end of the lima, attached it as a Y. The Y went to the marginal, and the lima went to the LAD. Here is an in situ lima to a marginal. You can see it's supplying the whole of the marginal system and how it's going through right here, the transverse sinus. Doesn't look like as the crow flies, but it's the way the heart wanted to do it. And here is an in situ lima to PDA. Remember, we talked about the turn point is right down here. This is extrapericardial, and then it feeds the PDA. A word about the ARCH trial. ARCH enrolled 3,102 patients across 28 cardiac surgery centers in 7 countries, and they were randomized to receive either single or double IMAs. Why is there no difference between SEMA and BEMA at 10 years? Well, it was meant to be a trial of 1 IMA versus 2 IMAs, but 40% of patients received other than intended due to crossover rates, CETA to beta, 4%. And when they were randomized to a beta, the surgeon said, oh no, it's not really for beta, it's a CETA, 14%. CETA with a radial artery graft, remember this, 22%. There was no difference in intention to treat because both groups had essentially the same number of arterial conduits. The big difference in as treated group, the significant improvement in both endpoints, all-cause mortality, especially to the composite. And the experienced surgeons had much better results at 5 years. Both endpoints, the curves actually started to diverge at 2 to 4 years, and even with intention to treat. Recruitment for ART started June 30th, 2004. So a paper came out in May 31st, 2018 in Journal of Dr. Maragadino, radial artery versus saphenous vein. And they analyzed 6 randomized controlled trials, 1,036 patients with half with radial and half with a saphenous vein. They found radial artery, lower MACE, lower occlusion rates, lower MI, lower repeat revasc. And Professor Taggart's paper came out January 31st, 2019, which is 8 months after we found out this. When Professor Taggart started this trial in 2004, there was no idea, no definite evidence that the radial artery was as good, almost as good as the artery. So recruitment for ART started in June 24, finished 27, and use of the radial artery was used in 22% of ART patients. So you can see how this would happen. Let's talk about the radial artery. Advantages compared to the ITA, the length advantage, the lumen is bigger, it's easier to use sequential, the thickness is easier to use, there's no contraindications for increased BMI or diabetes patients, decreased transfusions, lower sternal wound infections, and over time you can do concomitant harvest. They can be used in either direction. You can usually match the smaller end to the biggest artery. Disadvantages, a long incision of the arm, propensity for spasm, persistent sensory disturbance in about 10%. Endoscopic harvest, it does address incision, but the conduit may not be as long, and spasm can be managed by intravenous or oral medication. Less traumatic harvest by injecting a pedicle with Pavrin solution or using intra-arterial balloon pump for relieving spasm. This is the anatomy, and you need to know this. And these are the distribution of the two nerves. This is an example of radial artery spasm. At the beginning, it looks good, but sometimes the second or third reading, it's not so good, and then it gets better. This is probably because of spasm. And the way to deal with spasm is in prevention, is a injection of this bipavrin solution, and you're injecting the pedicle, not the artery itself. And this has prevented spasm since I've been using this 99% of the cases. Allen's test. You should perform it in all patients. 11.6% of the patients have unilateral negative test. A positive Allen test indicates the hand has positively adequate control collateral circulation. It drives me nuts because this is the only test that is positive and it's good. In my study or my database, 1184 patients had consecutive Allen's tests. 37 were negative with 3.125, 16 bilateral, 1.35%. False negative can occur as well. Contraindications, negative Allen's test, congenital atherosclerosis, infected IV site in a donor forearm, renal failure likely to need or already has an AV fistula, Raynaud's disease, and crunchy radials. Specks of calcium, okay. Diabetics sometimes have not very nice radials. There's relative contraindications, and this first one is important. Previous angiography via same radial 3 months. There is a 5 to 20% complete occlusion after radial artery procedures. One study showed the patency was 77% after pre-op cath and 98% without a transradial cath. The time range is from 46 days, range of 2 days to 6 months. Another one showed 9 weeks post-op impaired vasodilatation, and Dawson said it lasted 3 months. Also, naturally low blood pressure might not be good, and maybe a patient who uses both hands equally for a living, for example, a concert pianist. In my series of radial arteries, there was 1184 patients, 61% patients with a radial graft, 719 radial conduits, 965 separate grafts, and 214 sequential. The one thing I learned was you have to be very cautious with small radials, women and young patients. And sequentials are easier than an IMA, but the sizing length between the anastomoses can be more difficult because you have a pedicled conduit. It doesn't stretch like even a vein stretches more than this. And I've called them stretch 1, stretch 2, stretch 3. So here is the sequential radial to marginal PL through along the right coronary artery, and it's passing through a hole through the superior vena cava. And here is a radial to the marginal artery. You can see the whole marginal filling retrograde and antegrade. Saphenous vein grafts, important points. Saphenous vein graft solutions. Saline, even a short time in physiologic saline impairs endothelial vascular function. Wilbring's inconsistent in all studies. Saline rinsing and 100 millimeters mercury pressure causes 50% of endothelial cell loss. So if you're using saline back home, please change. Whole blood, some studies favor, but really no benefit. Plasma light with distension to 200 caused trivial endothelial cell loss. And plasma light with 1,000 millimeters distension caused only 30% loss. Solution is also very good, but very expensive. It's a commercial preparation. Vein graft failure, you can see here the saline and the blood on the outside is higher than the buffered in the middle. This is a graft level vein graft failure with the saline and the blood higher than the buffered. This is a paper by Ki-Bong Kim, South Korea, equivalent 10-year angiographic and long-term clinical outcomes with saphenous vein composite grafts and arterial composite grafts. This is the most important vein graft study, I believe, in 56 years. The first vein graft was done by Favaloro on 9th May 1967. He compared 10-year graft patency rates in long-term with composite Lita arterial versus Lita saphenous vein grafts. There were 380 and 103. Saphenous vein graft, they were extremely meticulous. No touch with pedicle. Immediately anastomosed to arterial conduit, either a Y composite or an end-to-end. The saphenous vein was left to be dilated by the native flow of the Lita. The valves of the saphenous vein were destroyed by inserting a 2 millimeter vessel dilator to reverse lumen, and previous studies had demonstrated a pressure trap in the saphenous vein distal to the valve. And this was done to avoid flow competition causing blood stagnation between the sequential grafts. So they used ASA and ticlodipine after for 2 months. Post-op angio was done early, 1 year, 5 years, and 10 years. And they used the Fitzgibbon ABO blood classification or graft classification. The results, number of bypasses, 3.5 versus 3.3. Optimal mortality was 1%. Post-op graft patency, saphenous vein group, 96.3%. The arterial group, 98.9% early. The 10-year saphenous vein group, 95.9%, and the arterial group, 88%. Now, this was not significant, but I said to myself, why did this happen? And the only thing I can think of is that possibly arterial grafts are subject to competitive flow. Why does this work? The saphenous vein is exposed to less circulatory stress. It's not anastomosed to that pounding ascending aorta. Saphenous vein continually is exposed to the nitric oxide from the internothoracic artery. Advantages, it avoids aortic manipulation and it increases conduit length. So why this is an extremely important study? Because use of vein in this manner provides 5 times the conduit length and same long-term patency as arterial grafting for construction of bypass grafts. The gastropompoloic artery, just briefly, a midline incision, 5 centimeters. If you touch the GA softly to prevent spasm, it arises from the superior mesenteric artery and then passes over the stomach and liver anteriorly through a hole in the diaphragm. Summa in 2013 found operative mortality to be 1.2%. Survival rate was excellent. 10-year patency rate, 66.5 at 10 years. And they actually improved this when they started to skeletonize the GA and use it only to tight stenosis. It is also subject to competitive flow as the mammary. Suzuki then reported cumulative patency rates of 97.8, 94, 90% in 5 and 8 years post-op. Professor Hiroshi Niinami from Tokyo presented his 20-year experience with total arterial grafting with BMA and GA. He uses the Focus harmonic scalpel to harvest, takes 10 minutes. He harvests the GA that requires denervation by removing the thin outer layer containing the nerves responsible for spasm. This is something new in the last 10 years or so, and this takes 15 to 20 minutes. So GA harvest, in addition to BMA, is by necessity metachronous, not synchronous. Therefore, can only really do 1 surgery in a day. It takes them 5 to 6 hours. I did 5 GAs in my early grafting period, and I thought, I'm going to just stick with the mammaries. Inferior epigastric conduit. This is from the abdominal wall. This is when you're desperate for an artery. It's the very few studies done on this paper. 1995 is the biggest one where he used 157 GAs and 157 patients. And early cath, they were all patent. Second cath, a year later, they were pretty much patent, but 8 showed diffuse narrowing. This is a systemic artery and more subject to propensity for atherosclerosis than either the IMA GA. There may be an advantage in synchronous harvest if the assistant is another cardiac surgeon or a trained physician assistant. And then Ayabi did 39 cases, and he used it with an I or a Y, and he found, interestingly, that the Y to the IMA was significantly better than the Y to the saphenous vein. Again, we're invoking the IMA nitric oxide secretion. So my take on PCI versus coronary surgery for CAD generally, and this is on my only slide on this, for syntax score less than 23, PCI is best for single vessel disease, acute coronary insufficiency needing immediate attention. Surgery is for CTO, chronic total occlusion, and proximal LAD. For syntax score of 23 to 32, the patient needs to discuss both with both interventional cardiology and cardiac surgery. The patient needs to know that in 5 years, he or she may be more likely to have a spontaneous MI or repeat revascularization, either with PCR or surgery. Discussion at triage rounds may help the decision. And for syntax score over or equal to 33, surgery. Comorbidities weigh heavily in the decision between PCI and coronary surgery. Surgeons need interventionalists. Interventionalists need surgeons. It is not a race. It is a relay. We hand off to each other all the time. Summary. Arterial grafts are inherently best conduits, but more expertise from experience is required. Some guides, not rules, are useful in certain patient populations. Saphenous veins may not be as durable as arterial grafts, but they can be made better with careful surgical harvest, handling, and attachment to an IMA. IMA supersede radials Other artery grafts, GA and IEA, can also have good results with experience and good judgment. PCI versus coronary surgery decisions need to be made with a disinterested love by physicians and for patients. Thank you. And here is a map showing Bahrain. Shukran.
Thank you very much, Professor Teresa, for that elegant presentation. You took us through a full textbook, really, here. We'll leave the questions. I'm sure that our fellow residents will have tons of questions, and we have till now 85 participants. I think all our residency program in Saudi Arabia and in the Gulf region are attending today. And we go to our last but not least, of course, speaker, Professor Faisal Bakin from the United States of America. He is a professor of surgery and surgical director of the Coronary Center at the Cleveland Clinic, holding the Sheikh Hamdan bin Rashid Maktoum Distinguished Chair. He previously led cardiothoracic surgery at Michael DeBakey VA Medical Center and Baylor College of Medicine. He trained at Cambridge, Mayo Clinic, and Baylor with 6,000 plus cardiac surgeries, and he specializes in multi-arterial and minimally invasive CABG and aortic surgery. He has more than 400 publications and holds leadership roles in the WATS, European Society for Cardiothoracic Surgery, and other professional societies. I think Professor Faisal is joining us with a recorded lecture. Welcome, Dr. Faisal.
Hello, it's great to be with you today virtually. I apologize that this is a recorded presentation. I'm currently on my way back from Europe to the USA. The Gulf Society for Cardiac Surgery is a wonderful society that I would love to stay involved with from this day onwards. I'm going to talk today about technical aspects of coronary artery bypass grafting. Let me just talk a little bit about CABG and why it's unique. CABG offers protection from today's lesions that cause heart attack, but also offers a prophylactic value in preventing future heart attacks. Because if you look at this study from Boston, in blue are the bars where the acute MI lesion is present, and it's usually within the first 70 millimeter of the coronary vessel, while the orange bars show where the distal anastomosis are typically sutured, and invariably they are sutured beyond where most culprit lesions occur. So that's the value of CABG. It protects against current and future lesions. This is a coronary angiogram of a 91-year-old diabetic. As you can see, the native coronary circulation is totally occluded. The right coronary and the left main are occluded, and that is 30 years after a coronary artery bypass grafting for 3-vessel disease and intact ejection fraction. And this patient is alive not because of medical therapy or stents. The only therapy that could keep this patient alive is CABG, and this patient is alive because of a single patent LITA to LAD that lights up the entire heart through collaterals. Now we celebrated the 40th anniversary of the seminal paper about the use of the ITAs or IMAs, we could use them interchangeably, in the New England Journal of Medicine back in 1986. So 40 years of proven value for the use of ITAs in coronary artery bypass grafting in terms of improving patency and outcomes. But how can we improve the advantage of CABG and compete effectively with PCI? Well, at the Cleveland Clinic, we've demonstrated that if you use 2 mammaries, it's better than using 1, but the advantage becomes manifest at least after 8 years, not before that. So you got to be patient to notice the difference in survival. And if you look at the as-treated analysis of Dr. David Taggart's ART trial, you see that when you compare multi-arterial grafting with a single ITA to the LAD, there's a survival advantage, and the hazard ratio for death is 0.81, and that is really consistent among observational studies. So who gets bilateral internal thoracic arteries and multi-arterial grafting in our practice? Well, it really depends on anatomic and physiologic considerations. When it comes to anatomy, we have demonstrated at the clinic that there's a survival advantage when you sequential that second mammary to bypass all important target vessels. And we define an important target vessel as that reaches greater than 75% towards the apex of the heart. So it's incremental additional benefit of bypassing not just an additional coronary besides the LAD, but you gotta touch down and bypass all important coronaries to get the maximal benefit. And this is an example of a patient that needs a LITA to LAD, but also would benefit from a RITA going to both lateral wall targets, the OM1 and OM2, because they're both important and reach greater than 75% towards the apex of the heart. And we believe there's a dose-response relationship between the myocardial mass supplied by ITAs and the survival, and you hit a saturation point or a plateau once you bypass all important target vessels. One strategy that we use to hit all important target vessels and reach to them easily is the extended zone RITA, or what we call easy RITA. We only take the right internal thoracic artery that is in the lower part of this slide. The head is to the left, the legs to the right, and we create an end-to-side anastomosis with a vein or a radial artery, and that construct, that easy RITA, would allow it to reach anywhere you want. And the advantage is that it's faster because we only have to harvest the right internal thoracic artery halfway down the sternum. You minimize the chance of sternal wound complications, and you maximize the reach of the RITA. Well, if you believe the SAVE RITA trial from our South Korean colleagues, that vein or that radial that comes off the RITA should behave exactly as an extension of that artery. So it becomes arterialized, and it is protected by the nitric oxide and the low pressure system that's associated with the inside ureta. So I'm going to just play this video.
This is a demonstration of how we set up the
See
easy
excellent
RITA
flow,
technique.
and that
The
vein can be
is
wrapped around the
anastomosed to
heart.
RITA. Shown here is the end product with excellent flow through the vein.
And it's
The
easy
RITA
to
is
set it up,
harvested in a skeletonized fashion
and
to approximately halfway down the sternum.
it's easily
Then split
constructed.
and pressurized. In this
We've got
case,
a
the
nice
RITA will be
complete
routed
video that we
anterior
can
to
share
the
with you.
aorta toward lateral wall targets. The RITA is put under traction using a bulldog with a hemostat at its end. An appropriate length of vein is selected to extend the RITA. The
Of course,
vein
you
is
could use a radial
spatulated.
as well.
A 5 mm arteriotomy is created approximately 1 inch proximal to the distal end.
And then you construct an end-to-side anastomosis just like you do for distal coronary, right in front of you.
An end-to-side anastomosis is then performed, similar to a standard distal anastomosis, on a still field directly in front of the surgeon, providing excellent visualization and facilitating the operation. After the first 2 sutures are placed, the vein is parachuted towards the RITA. Most of the anastomosis is performed by the primary
And the rest
surgeon.
is self-evident, really. But that we find is a very useful way to extend the reach of the inside ureta. And
This is a
I think the presentation stopped.
ICOM technician, the ICOM technician, please.
Yes, we are working on it, doctor.
Maybe we can use this time, Dr. Habib, just there is Muhammad Lahmar is asking Professor Mustafa, thank you for the amazing lecture. What is your advice for early career cardiac surgeons? This is Dr. Lahmar from Algeria.
I think by looking my past years, what I learned and I can advise. This is the opportunity to share our experience. So first, read and learn a lot, and it's a sign you are just following this webinar to make the good basis of the theoretical knowledge. This is the first part, and the second, practice. Practice means you need to see so many surgeons. I'm so sorry to talk like this, but you see how to do it and how to not to do it by seeing many different techniques. You may like, and you can combine with different techniques by seeing different surgeons, your own technique, and the volume. You need to get trained in high volume centers. It doesn't mean you have the opportunity, always depends the volume, but if you don't enough volume in your center, which you complete your basic training, then you should get the fellowship programs in order to improve your surgical background and surgical handlings, high volume centers. So those are main things I can tell to you. I say when the airplane is taking off, you cannot decrease the speed, otherwise you may have a crash. So you are young, you need to work hard, hard worker, and yeah, I mean, perhaps you need to think your life-work balance. Also, it's important. But our generation, we were almost living in a hospital day and night, and therefore we get the good level and surgical experience.
Thank you very much.
Sorry to interrupt. We're ready to go back to the record.
Yes.
Yeah.
We'll carry on then.
We're going to publish that soon and present it in details at the upcoming AATS. But also we have to think about minimizing the access and minimizing the invasiveness of a CABG. And we all know how to do the mid-cab. This is a mini left thoracotomy with this rib lift that allows you access to harvest the left internal thoracic artery and do it under direct vision. However, this is the kind of view that you get. It's kind of dark and deep, and in fat patients, in obese patients, this could be a hard procedure, especially to get enough length at the distal end of the lita. So again, we've done that for years now, and it's gratifying for patients who have the anatomy and limited vessel disease to allow you to do that. But it's not a perfect visualization, and it's not the most technically easy operations in some patients. Now compare that with using a robotic assisted approach for harvesting the internal thoracic artery. So this is a robotic assisted mid-cab, and we start by opening the pericardium, and we do that with hemostatic control, and we immediately identify an accessible LAD, so that is a reassuring finding. And then look at this 10 times magnification, lighter, perfect visualization, except for that little smudge here, I guess, that we have in this particular video. But the point is that you could do this with a small incision. You still have to spread the ribs, and it could cause a little pain. But we at the clinic will be moving to completely robotic approaches in the next couple of months, not just to do a LITA to LAD, but to do complete revascularization of the heart. So stay tuned. But in terms of the mid-cab results, we have quality control in the OR with a flow meter, but also especially in our early experience, we did CTAs prior to discharge, and this is an example of a perfect anastomosis for a mid-cab. What about coronary aneurysms? I know this is not CABG, but I think it involves CABG, and we're seeing more of those, especially after COVID. And here's an example of a right coronary artery that is huge, and it's associated also with a fistula to the coronary sinus. So the way to deal with those is to do an in situ reconstruction, exactly like you perform for an abdominal or thoracoabdominal aneurysm. So you fillet the entire aneurysm open from its proximal to distal end, and then you use a vein or radial artery, and you construct sequential anastomosis after you ligate the fistula in an end-to-side manner, and basically reconstruct the right coronary artery to what it should look like. And this is the end product where the vein comes off the aorta and is sequentialed, in this specific case, to 7 anastomosis, and ends in the 8th one as an end-to-end anastomosis, and that's how it looks like. What about high-risk CABG? We're seeing more and more of those, and technical aspects are quite elaborate in those situations. So let's just give you some examples. But before we do that, we need to define high-risk CABG. You could argue that it's a predicted risk of mortality of greater than 8, meaning 8% mortality, or it's a referral by another cardiac surgeon to you, and I think the latter may be more telling. But if you look at it objectively, the most common are usually poor targets or conduits and prior sternotomies, and this is based on a registry whereby patients were declined for CABG and received PCI, and those were the reasons listed for surgeons turning those patients down. When I particularly look at the situation, I classify high-risk CABG into a hostile anatomy or hostile physiology. Hostile physiology we are more concerned about because you could do nothing about cirrhosis, you could do nothing about frailty or bad RV function or shock with organ failure. I mean, you could use mechanical circulatory support and try and reverse some of the organ failures, but these are usually high-risk patients that we can't, as surgeon, technically influence the outcome. It is the hostile anatomies where we're really not deterred because we know how to handle those complex anatomies very well. And let's give you some examples. Let's look at poor conduits and targets. This is definitely a poor conduit. We would never use such a vein. It was given to me and I basically discarded it. It's a very varicose vein and very thin vein in a rather young patient. And as you increase the pressure, you can see this is a piece of sausage that's leaking. And then I decide to further jack up the pressure, and you will see what happened at extreme pressure. So if this patient goes to the floor and his blood pressure goes up to 200 systolic, they could rupture and exsanguinate. This is a situation where we needed to do multiple bypasses, but we were short of conduits because the patient had unusable radials and both greater saphenouses were used for lower limb bypass. So in this specific scenario, we decided to create a composite. And we used the lesser saphenous vein, and at the clinic, we used the mammary retractor to lift up the leg, and we could harvest the lesser saphenous vein endoscopically, and that gave us a nice lesser saphenous vein. And what we did
We lost the sound.
in this particular case is take the Lita is here with the bulldog on the left side, and then the Rita is a composite of the Lita, and then we extended the Rita with the lesser saphenous vein, and you can see we could bypass the femoral artery in this guy. But with this construct of composite, the Lita has excellent flow, the Rita also has excellent pressurized flow, and this small lesser saphenous vein, as you will see shortly, has good flow. So in this specific case, we used the Lita to sequential OM1 and OM2, and we used the Rita to bypass the distal LAD, and the lesser saphenous went to the PDA. What about poor targets? Well, we never get good targets anymore, right? So this is a case, you see the LAD is diffusely diseased. We could give this patient a bypass, but we can't give them a target. Nevertheless, in this case, we decided to give them a target by doing an endarterectomy. And this is the kind of stuff that you get out. You got to be careful to get the entire plaque out and try and tease out the septal and diagonal branches so that you don't occlude them. What about metal jackets? We're seeing more and more of those. If the vessel is not totally occluded, I keep the metal jacket in and I just go distal to the metal jacket. And as you can see here, we did a Lita to the very apical LAD, and that mammary should stay open and hopefully should keep the LAD open because it releases nitric oxide and provides a field protection to the LAD. Cabbage, and not all redo cabbages are risky. The ones that involve a patent Lita that's at risk are probably the risky ones, and let me just show you an example. This is a patient with a tight left main, and as you can see, he needed a redo cabbage, but if you concentrate on the cath, you'd see that the Lita is tethered to the midline, and we suspected that it's attached to the sternum, and this patient needed the lateral wall target bypass, so we needed to do a sternotomy and mobilize the heart to get access to the circumflex. And we did a CT scan, and sure enough, as the red arrow demonstrates, the Lita is in harm's way, right in the middle of where we're going to do the sternotomy. And this is another case where the Lita is actually tethered lateral to the sternotomy against the chest wall, against the harvest bed, the harvest site of the Lita. So obviously, if we need to get access to the lateral wall, we have to mobilize the heart. But to mobilize the heart, that Lita is stuck to the chest wall, and it's obviously a very high-risk scenario. And this is the CT scan, again showing with the red arrow that this mammary is totally stuck with no planes between it and the chest wall. Now, oftentimes we go in and carefully dissect that Lita without injuring it. And the way we do it is we use an oscillating saw to divide the anterior table of the sternum, and we lift on both edges with the sternal lift and use a scissor to cut the posterior table from the xiphoid heading up superiorly to the manubrium. And most of the time we're lucky and good, and we protect where my pickup is where the graft crosses the midline, but sometimes we do get into the graft, and you got to be ready and not panic to the extent that we could do a video and take our time. Why? Because we are on bypass on using peripheral access, and we're going to quickly achieve control, protect the heart, and perform the surgery safely. We have experience with over 32,000 reoperative procedures, including bypasses and other combined procedures, and we believe that surgeon experience and institutional experience are important to mitigate the learning curve. Now, we should always be ready to improvise. Here's a case where a patient had a Lita to LAD with a technical problem on the left side at the distal anastomosis. Here, all we did is a baby vein jump bypass bridge from the distal leta to the LAD, and that's a CTA showing that this is patent, and this vein again should behave as an extension of the ITA and be protected and be durable solution. And this is a case that was referred to me with the leta bypass to actually a vein that lights up the greater vein and the coronary sinus, and all we did here is to recycle that memory. We identified the vein in blue arrow in the middle here and the artery much deeper to it intramyocardally here. So we detached the leta from the vein and overshot the vein and bypassed the true LAD, and the patient did well. So in summary, CABG has a therapeutic and prophylactic value that's unmatched by PCI. We can maximize the benefit of CABG by using more arterial grafts and decrease the invasiveness of CABG. We are seeing sicker patients and more complex anatomies. That's why CABG should be a subspecialty, and you guys are the future of CABG, and I'm sure that CABG is going to be in your safe hands where you're going to innovate and raise the flag high. Thank you very much for the honor of presenting today, and I look forward to staying in touch with all of you.
Thank you very much, Professor Faisal. And we have come to the discussion now. So we have a couple of questions that we need to go through. The second question was about a patient who developed mechanical complications such as papillary muscle rupture post-MI. How would that change your approach to the patient? Mustafa?
Thank you for the question. These are the complications day after day we see less and less. I mean, I remember when I was in training, we see the aneurysms, VSDs, these kind of mechanical complications, free wall ruptures. But now, thanks to the speed of the percutaneous revascularization and fibrinolytic treatments, we don't see these kind of patients. But still, there are some patients lately diagnosed and coming with mechanical complications. These kind of patients, when I see in my institution, first reaction, intra-aortic balloon pump, post-MI VSD or papillary muscle rupture, you need to decrease the afterload. And then depends if there are some end organ failures, the patient is in a good shape for heart surgery or not, we can take to the operating room. Generally, we perform the coronary angiography, but generally those are the terminal complications of the completed ischemia. There is no viable myocardium, and it's debatable to perform in these regions the coronary bypass, which is not always benefic. If the patient is not stable and not in a good shape concerning the end organ functions, we put ECMO and sometimes the impeller deloading to earn a little bit time and to precondition the patient, prepare the patient for this surgery. And I mean, these kind of patients, there are some techniques advised, I should say, repair, reattach the papillary muscle, like mitral valve repair. But in this subgroup of patients, I should be honest, so I don't use, and honestly, I cannot advise from my part to repair the mitral valve, just I replace. And even out of the patient's age, generally those are the patients around 70s, so biological valve, but even young patient, I can use biological because those are the complex patients, can complicate the postoperative period if you use the mechanical valve. And so concerning the access, it's also tricky because those are the acute pathologies. You cannot always safely use the direct left atriotomy, which you are using for mitral procedures. For this kind of small patients, small atrial patients, I use the transeptal or superior septal approach called Girardon. I have also paper published in Texas Heart, I think 2-3 years ago. So those are the pitfalls for young surgeons for this kind of surprised, unexpected pathologies and rare pathologies.
What do you do for the stented vessel that this patient have? For example, this patient is stented, developed papillary muscle rupture, and you need to operate on them. This recent stent, and you have to operate and reverse the anticoagulation and all this. What do you do for the vessel at that time?
If there is no more competition, there is not guarantee your conduit will stay patent. Generally, I don't touch to the already dilated, treated vessel. But there are sometimes we are teasing. Also, you can just crush to stent and make a bypass. But I think it's already treated lesion, and there is no need to put another bypass. So those are complex patients. I think these patients, they don't need to invest in long term in the first hand. They need to leave the hospital alive. So whatever complexity you will add to already a complex situation, it can be harmful for the patient. This is my think tank.
Another question is related to decision making. Somebody with triple vessel disease with probably the three vessel with proximal LAD. The question that arises is that would this patient benefit from 4 or 5 stents or long-term benefit of Lima to the LAD and CABG rather than go for multiple stents?
I think the young colleague should understand. Ahsan Ehtestam asked this question. So when I'm saying think PCI for ongoing ischemia, you need to understand ongoing ischemia, it's a big suffer for the myocardium. And myocardium, it's an organ, can lose the viability within following 30, 60 minutes. So, and generally, there are culprit lesions responsible for this STEMIA. It's not, it's not regular stable coronary disease we are talking. Those are ongoing ischemia STEMI patients. So in front of this situation, with my experience and in my institution or whatever institution, I think nobody can say we can revascularize the patient as fast as the PCI. No, I mean to move the patient, prepare anesthesia, prepare the conduits, it will take at least 1.5 hours. But in my center, from the door to cath lab or revascularization, it's 34 minutes. So based on this, I advise treat the culprit lesion and then let the other lesions to discuss or reassess. So in this case, the colleague was asking 4 to 5 stents. This is a bad approach. Many studies, many debates are ongoing cardiology side, but mainly cardiologists, my cardiologist also, they don't treat all the lesions on ongoing ischemia patients. Just there is a lesion, coronary artery, or marginal, or maybe even LAD. So put the stent on this one and let the patient to cool down, and then after discuss the upcoming strategies. There are so many patients coming to my institution with ongoing ischemia, right coronary artery lesions, and they dilate not 4 to 5 stents, just 1, 2 stents on right coronary, and then the rest actually completing the antiplatelet DAPT about 2-3 months. I take to the operating room in order to complete the left side with surgical revascularization. But don't forget, these are ongoing ischemia patients, which I am talking, I advise PCI. If the patient doesn't have ongoing ischemia, of course, surgery is better than to put 4 to 5 stents.
They come either, for example, occluded vessel, that is acute ST elevation MI with occluded vessel. That has to be open immediately, obviously. You should not wait with that lesion. Sometimes...
And another information, intra-aortic balloon pump, he's mentioning intra-aortic balloon pump can stabilize the patient, can give you the time, but it's not opening or revascularizing, giving the normal coronary flow. So it's just a useful tool, but it doesn't solve the main problem.
The next question for Professor Teresa, and it's related to gastroepiploic artery in CABG. And I don't know about this information, but it says that gastric block artery behave like a splanchnic artery. It dilate after meal and constricts while fasting. And if so, do you advise patient dietary change, small frequent meals to prevent intermittent ischemia if this gastric block artery have such reaction?
That's a very good question. It does dilate after you eat a meal, and it probably is a good idea. I have not done that many to know that this is the thing to do, but it makes perfect sense. It really does. That's cute because I did read that it does dilate after eating. It doesn't lose its mother country, which was near the stomach. Thank you for that question. That's lovely.
Yeah. And the other thing, can you explain about REMA extrapericardial in order to reach the PDA? Extrapericardial.
You want?
He said he wants more explanation about REMA
Okay.
and extrapericardial. That's
Yes, I'd love to do that. This is, you hear very often people say you cannot get the REMA to the PDA. You can. If you skeletonize the artery, first of all, it's longer, it stretches. And I learned this from a surgeon in Bern, Switzerland. This was not 2003. We were talking, and he said, "Oh, he says it's easy. You just put the hole, bring the mammary outside the pericardium. So you have to have opened up the pleura. You bring the mammary outside, I guess at this side, because you're looking at me anyway, outside the pericardium. And then I look and see where is the PDA, and I make the hole down low, not near the phrenic, you have to stay above the phrenic, a little hole right down the base of the heart, or the tip of the heart. So the mammary comes outside the pericardium. It does not lie in the right atrium. So it's wonderful if you're doing a redo. I've done redos, and I go, thank God I put that mammary there because it's not going to get in the way. And so the turn point, it turns at the reflection of the pericardium like this. So, and it goes true on the heart so that the mammary is lying on line like this. It's not lying like this, but every time the heart beats, it twists the mammary like that. Can you see what I'm doing here? And so if you bring the mammary through that hole, low down, onto it, lies true on there, and it works. And it somehow is longer. By the time you harvested the mammary, by the time you come to use it, it's gotten a little longer. One time, I mean, not probably more than once, but one time I remember very clearly because I was using transit time flow in the first year and it didn't work. And I had to take off the mammary and put it as a free graft on the aorta. But that's one in about, I don't know, hundreds and hundreds. So does that help the questioner?
Yeah.
Does that make sense?
I think so.
Okay.
So, Dr. Adil.
Thank you.
Yes, I have a question myself, and then we'll go back to the questions to Professor Teresa. What about patients with renal failure who have a shunt on the left arm? Would you do a Rita to the LAD instead of a Lita?
Yes. Yes, I would. In fact, Nakajima just came out with a paper that said you had to have, he did a study where you looked at REMA to LAD and LEMA to LAD with shunts. And he found that when the stenosis of the mammary or the LAD got to be 90% or more, it really was a problem. They did not get enough blood. So on a lower stenosis, he found there wasn't a problem. But you don't know that stenosis isn't going to progress. So to be quite honest, with a shunt, I would either use the LEMA as a free graft to the REMA or to the aorta, or use the REMA crossing the chest. But I'm not wild about the REMA crossing the chest. I know I'm never going to reoperate these people, but if you do, it's a really nuisance. It's bad. You're going to be cutting it in half. So I prefer to keep the midline free. Mind you, we have minimally invasive now, whatever. But yeah, I would use the REMA in some fashion.
REMA crossing, that is the Cleveland Clinic, isn't it? They do that.
Cleveland Clinic crosses or doesn't cross?
Yeah.
David Taggart does it too. He crosses the midline all the time. He does the REMA to the LAD all the time. I mean, it's sometimes very nice because it just it's so long, it goes over the aorta and finds the mid LED very easily. But I'm just kind of worried. And what if you have to suddenly do a redo if your colleague has to take the patient back for bleeding, doesn't know you've done this? Bang, it's gone.
I agree.
There was one question about injury to the lemur. What do you do if the injured the lemur during the harvest?
During the harvest? Okay. If it's just a little side branch that's pulled off or whatever, I repair it with a longitudinal 8-0 prolene. Okay, if it's a tiny pinpoint. But if it's damaged, like say at the top end, it's a fray graft, or in the middle side, it's a Y graft. I still use it as best I can. I use the pieces. I believe so strongly in the mammary artery, and I've seen it again and again in follow up with my patients. So I don't just throw it out. I think that's a sin, throwing out a mammary.
So what about using, like, for example, if you had an injury in the middle of the lemur, using the proximal part and then doing the extended zone, a vein attached to that
Yes,
lemur, which, as
that's
presented, it acts like a lemur in the long term.
yes. No, I would do this now because of this paper that I really stressed in my talk. I think it's amazing. I think the vein can live with the lemur giving it nitric oxide. What I don't know is what if you do it the other way around? What if you put the vein on the aorta first and then attach the mammary? Is it going to do the same thing? Does it go backwards? I've had to do that a couple of times, so I'm just kind of keeping my fingers crossed for these patients because I don't want them to develop a proximal stenosis where I attach the vein because I'd done the distal already. It was a dissection, it was a lemur dissection that had happened. And I had used a good piece of lemur, but unfortunately it still had a section that I should have removed, or it was too long, it was long enough. So I put a vein to the lemur. But she did fine. She never came back. But I'd like to know if the nitric oxide goes both ways.
That's interesting.
Good question. Thank you.
Dr. Habib?
Yeah, there's some question in relation to, do you protect the heart for possible redo at the end of your surgery or not?
And how so? You mean?
For example, do you put, there's a lot of fat on the pericardium at the end of the procedure.
I see.
You put that fat on the heart rather than just the pericardium so that you avoid constriction. So do you sutures the heart?
For a redo.
Yeah.
If you're trying to protect the heart by putting some like omentum, and they used to do in the days of the Weinberg, to protect the heart on re-entry. Is that what you're saying?
Yeah, not pericardium, but there's a lot of fat on the pericardium outside
Yes.
pericardial fat. Do you suture that, especially if you take Lima and Rima, you will have abundance of these fat. Do you suture them together to get protection for
no,
the
I
heart?
do not. No, I do not. But I think it's probably a good idea. I just have never seen. I don't know if anybody does that. I know from the Weinberg days, they used to put the omentum on the heart, to protect the Weinberg.
Myself, if I take Bima, then I'll have a lot of fat actually. So I just protect the heart by suturing this. It's very nice to see the heart.
That's very nice. That is very nice. No, that's a good idea. I might try it now. You learn so many things, Mustafa was saying you learn so many things from watching other surgeons. I have been to so many ORs all over the world, and I never come away without learning something. Yeah. And I thought that's a good idea.
One of the trainees asking how many anastomoses you must train on simulator in order to start doing a patient.
Oh, that's a good question. Who is I'm just trying to think of the surgeon who did all these courses in anastomosis. Oh, it's not, you know who I mean. He said he's from Belgium. Oh, what the
surgeon,
hell?
Surgeon.
Who is
Professor Surgeon?
Sargent, yes, that's right. Yes. Paul Sargent, oui. And he says you have to do 1,000 anastomoses on a simulated before you touch a human being. Now, I think that's a bit of an exaggeration. I think that person shouldn't really be in the surgery specialty. They're taking too long to learn. But you can do this yourself. Amazon is incredible. You can buy a little kit. I have them because I used to teach my residents in my office. Before they were going to do a proximal for me, I'd have them come down and I'd go through 2 or 3 anastomoses with them in my office from this little kit I got from Amazon. They even had ring tip forceps and needle drivers, the pinchy needle drivers, I forget what they call them. And I would make sure they got to the point where they could do it at my satisfaction. And then I said, okay, you're ready. And it only took 2 or 3 times. They're fast learners, or else they went home and they practiced themselves. So I don't think it takes 1,000, but I think it's a very good idea to get to a wet lab. To go to the wet labs at EX if you're going there. The wet labs at EX Academy are wonderful. They have heart and anastomosis for 4 hours. We teach them how to sew. And a lot of them know already because they're very advanced. It's a good question.
Do you face intramyocardial LAD? Because in our area, we see a lot of patients with intramyocardial LAD, and what you see is only near the apex, the LAD. What do you do for these patients?
Oh, I have a good story on that one. I had a patient who had an very deep intramyocardial LAD, and if you really want to see how far it goes or where it is, use epicardial ultrasound. I used epicardial ultrasound, and this was like a full 2 centimeters below it. It sort of dipped down like this and then up to the top. And at the distal part, it was like 1 millimeter vessel. So I thought, I don't want to go there. It's just fraught with difficulty. So I went to the very, very top where there was a diagonal, and I just went into the myocardium a little bit, not very much, just to do the anastomosis, just beyond the diagonal. He came back in 3 months with it occluded. So I thought, oh, gracious, oh, dear God. So I brought him back, and I did the anastomosis. I think I reused the mammary and brought it down and to the LAD. And actually, I think I did a sequential to the diagonal as well, or maybe I did with some piece of vein. But I had to redo that because I had tried to bypass in the intramyocardium, and I did the LAD, limited distal LAD, or whatever it was, no problem. And I was using ultrasound and transit time flow, so I knew the bypass was good. I think this is not a plug for that, but it really is important to do intraoperative graft flow measurement, and imaging is huge. Imaging is the final answer when it comes to if you use either transit time flow or imaging. If I had to pick one, and I only had one, I would pick imaging, because it's like an intraoperative color angiogram. So I knew I had a good result, and he came back, follow up, no problem, and I've never seen him since. So yeah, that's a problem. Thank you.
That's something about this intramyocardial LAD. So actually, I can combine with another question. What are your nightmare cases for coronary surgery?
That's right, yeah.
One resident was asking.
Yeah.
I mean, these kind of patients, they are not regular patients. Imagine a piece of butter in front of you, whole yellow, and just you are searching the artery. Generally, it is something like this. It's on a regular, not fat heart. You see, you are
Mustafa,
able to.
Intraoperative epicardial ultrasound will tell you exactly where it is. It doesn't matter, it has this much fat. It really is a useful tool.
The other problem, you go deep dive, but sometimes, for example, one of my latest patients, a lady, it was not intramyocardial, it was next to the endocardium. And when you go deep dive, almost, it's like unescapable, you open the right ventricle. And this is somehow, you start to, feel the sweat is going to your coccyx. So what will happen? So you need to find, okay, you can use the ultrasonography, but not in everywhere. Then you can use also the distal part of the LAD and make a small arteriotomy and put the sound, because theoretically we know the distal part, 1/3, 1/4 of LAD also you can ligate for even trauma patients. You can find like this, but you should be careful. You can go very deep. And when you go deep and you open the ventricle, then you have a problem, solved problem. You found the LAD, And to solve another problem, how you will close this ventriculotomy, which you did, it should be with very teeny sutures with the pericardial patch. You can, and you should not try to make very big hemostatic patch. It's a low pressure system, which I passed the period like this. The graft is patent, and I made the imaging studies. There is no pseudoaneurysm, something. But you can get these kind of patients very near misses or nightmare situation. And I can tell to you, to be safe surgeon, okay, you are not able to find, you are not able to solve the situation. You can put also on diagonal and just you can accept you are not able to. It's one in a, not million, but 1 in 1,000. But don't think you are a magician, which we think you know the joke. What is the difference between God and the surgeon? They say the God knows, he is not surgeon. Surgeon doesn't know, he is not the God. We cannot solve always the problem. So try to leave the operating room with a live patient, of course, with complete revascularized myocardium.
Yeah. One of the nightmare, obviously, in the LAD, if you dig and you don't find RV perforation, and then you get a major problem. This is one of the things that you try to avoid.
May I just add one little thing for intramyocardial arteries? You cannot bypass them. This is what happened with my case. I went just a little bit in the muscle. Cardiologists cannot even stent intramyocardial arteries. The muscle is so strong, it will close a stent, and I can't even collapse a stent when I try to. It's really hard to take it out, and you go, I can't even. So just one thought. Thank you.
The question about radial artery, do you put this patient on calcium channel blockers after surgery?
For me, for Teresa?
Well,
yes.
Radial artery, so Teresa, yeah.
Okay. Well, I do. I put them on diltiazem for 6 weeks, and I remember asking Brian Buxton, how long should we use these channel blockers, these calcium channel blockers? And he looked at me and he smiled and he said, for about a week. So I don't think he really, we do it because it's motherhood and apple pie, and we don't want to, but yes, I do.
Yeah. Okay. Dr. Adel, any questions?
No, from my side, I think we covered the topic quite elegantly with the elegant speakers that we had. And I'm just scrolling through the comments from our fellow participants and attendees, and I don't see. Yeah, I think we covered most of it. Yes.
Very good.
One thing one thing we did not mention in preparation, and we mentioned some of the medication of importance, and these days now the SGLT2 inhibitors, which is very commonly used, these also need to be stopped 2 to 3 days before surgery. I think it's if you agree with me.
Yes.
And one advice is that patient who has very poor ventricle, I don't know whether you agree with that statement or not, very poor ventricle and very poor diffuse vessel disease that is very poorly, could be revascularized. These patients are very difficult, and maybe it is not pertinent that you put them for coronary artery bypass, poor LV and poor vessels, poor target. What do you think of this statement?
Well, I think we've all done these cases, and if these are the people that need the most help. So I would very carefully look at the angiogram and see if it was a way I could do an endarterectomy of either the right or the circumflex, or not the circumflex. It's hard to do the circumflex with the LAD I would have done. It would have to be something like, I don't know, I think I turned down a patient who had 2 carotids, 99% stenosis, and could not be stented, that sort of thing. I think, I would look for some viability. I would see where the territory of ischemia was, and if it was a reasonable target. I mean, we all do cases, especially nowadays. Gone are the days when we had smokers who damaged perfectly good arteries. And you go, 3 millimeter LED, no problem. They don't exist anymore. So you might end up turning down a lot of cases. I never turned down too many. I would always find a way of doing something and have a fallback situation, make sure they had access for a balloon pump, make sure they didn't have atherosclerosis of their groins and that sort of thing. So I think, and I discuss it with the cardiologist, say, look, is this one you could stent, because it's a really diffuse vessel. We will work together. I would work with the cardiologist a lot. I do that a lot. But I'd have to see a case that I would turn down, because I have not turned down too many, to be quite honest. My chief trained me, and Willie Keon in Ottawa Heart Institute, and he was always given the cases nobody else wanted, and I would see him do incredible things. He was the master of endarterectomy, and I do many endarterectomies as well. So I don't know how to answer that question. I really like to help. I don't like to hurt, though. So
Okay, Mustafa.
We do some studies in order to prove if there is an ischemia and there is a viable myocardium. In that case, even the patient is fragile, needing a lot of bypass, we do. But it's related to another question also. I think the preoperative investigations, which I mentioned, MRI and PET-CT, this kind of studies helps us to decrease the complexity on fragile patients, because if there is no more myocardium, we don't need to put the grafts and make the operation more complex. But in case if needed, I discuss with my team and with intensivists and prepare precondition the patient and other colleagues for postoperative mechanical support, and then fully revascularize a failed heart on a fragile patient.
Okay, Mohannad, do you have any questions, any comment before we leave? Mohannad?
I would like to thank our speakers for this excellent and insightful presentation, and for Dr. Habib and Dr. Adil for guidance of this discussion. It's really very insightful and very beneficial for us as a trainee. Thank you very much.
Okay, and I think
think
time is over.
On our presentations also, it's written our contact informations, because there are some questions I saw we are not always replying fully, but they can contact us, and I am fully in their service to help and reply to our young colleagues, which are the futures.
Yes, and our emails, I'm sure, are on CTSnet, so you can contact us anytime with questions. Please do. Thank you for this beautiful, so well organized session. You guys are awesome.
Thanks.
Also to the technical team, which is very professionally prepared. Rehearsal was perfect. I mean, failing to prepare, preparing to fail. It's very well prepared, and we are concluding with a good result. There are so many also attendees. I saw about 90 people almost with us. Congratulations. Thanks a lot.
Thank you very much, and appreciate your contribution, Professor Mustafa, Professor Teresa, Professor Faisal. Thanks to my colleague, Dr. Adil, Dr. Mohannad, and obviously the ICOM team. Thank you very much for this lovely evening. A lot of education, a lot of learning and interaction. Thank you very much, and hope to see you sometimes in person. And have a good night and good morning, good afternoon.
Good afternoon. Good afternoon. Good afternoon.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.